Welcome everybody to this webinar, PCR webinar on secondary matter regurgitation. My name is Francesco Maisano, and I will be the chair of this webinar, where we will learn about the newest evidence on interventional management of secondary MR. We will discuss this latest evidence, how this will maybe reshape our daily clinical practice. We have been, in the last 20 years, experimenting new options for patients with mitral regurgitation. There's been a long distance between Mount Everest to the Matterhorn. We will see how these two trials compare somehow. And in Europe has been influential back in the early days to experiment the role of transcatheter edge-to-edge repair in secondary, at that time called functional MR. We published, many of us, this publication on Access Registry, which was a real-world registry, including many patients with secondary MR. But we learned a lot from there. There has been the COAP trial, there has been the MATTERHORN trial, a lot of discussions going on. And recently, two trials are filling some of the gaps of knowledge, specifically in patients with less than severe MR and patients with who can be treated with surgery. But without disclosing all the secrets of this webinar, I want to share with you that we are going to discuss what the data say within these two trials, the RESHAPE 2 and the MATTERHORN. We will discuss how to interpret the evidence and how this new evidence will impact our practice. I will be supported by a great team of physicians, Yuda Grapsa from London, Volker Rudolph from Germany, Gerasimos Philippatos from Greece, and myself. And I welcome my friends here to have a discussion. Welcome Gerasimos, Julia, and Volker. And without further delay, I'd like to introduce Gerasimos Philippatos, who has been one of the executive committee of the RESHAPE 2 trial. And let us know, Gerasimos, what did you learn in this trial?
Thank you very much, Francesco. Thank you for the opportunity to present the results of the RESHAPE heart failure 2 trial. And I'm sure that we can discuss at the end, and you can tell us why this trial has the name RESHAPE heart failure 2 and not the RESHAPE heart failure 1. This is the design of the trial. As you can see, 505 patients have been randomized in a control group with guidelines-directed medical therapy versus mitral clip, with a follow-up of at least 6 months of the last patient. And also for the all-cause mortality, the average follow-up was 3.5 years with up to 80 years of follow-up. These patients were in New York Heart Association class 2 to 4 with an ejection fraction from 20 to 50%. And if the patient was a New York Heart Association class 2, should have been in a more advanced functional status in the last 6 months, with significant functional mitral regurgitation. These were the primary endpoints of the trials. We've chosen to have 3 primary endpoints: recurring events of cardiovascular death or heart failure hospitalizations, recurring events of heart failure hospitalization, and KCCQ, Kansas cardiomyopathy questionnaire change from the baselines to 12 months. The statisticians always make things more complex for us, and you need to have some p-values, as you can see, if you have 3 primary endpoints to consider the result significant. And this p-value in some cases is less, as you can see, than 0.05. Let me compare the patient characteristics of repair with coapt and mitral clip. You can see the age, the GFR, that was a little bit lower. The median NT-proBNP that was 2700 and the mean more than 4000. The left ventricular ejection fraction was the mean left ventricular ejection fraction was 31, and you can see that the mean EROA in the trial, in the RESHAPE-2 trial, was 0.25 compared to 0.14 coapt and 0.31 in mitral FR. And you can see the difference between the three trials in the main in the 6-minute walk distance at baseline. So if we want to summarize the difference in characteristics, I think that you can see the patients in RESHAPE probably characterize a third distinct population with more patients with moderate to severe functional mitral regurgitation. You can see here the effective regurgitant orifice area compared to the left ventricular and diastolic volume of the three trials. And this is the first primary endpoint, recurrent heart failure, hospitalization, or cardiovascular death within 24 months, and there was a 36% relative risk reduction. The second primary endpoint was recurrent heart failure hospitalizations within 24 months, and you can see there was a 41% relative risk reduction. The third primary endpoint was the change from baseline of a period of 12 months in the Kansas cardiomyopathy questionnaire, the overall summary score. And as you can see, there was a 10.9 points difference between the two arms. These are the main secondary endpoints: the decrease in mitral regurgitation less or equal to grade 2 at 12 months. You can see that the difference was significant between the two arms. The mean change in 6-minute walk distance from baselines to 12 months, and you can see there was a difference of approximately of a little bit more than 20 meters. The rate of death from any cause during the complete follow-up per 100 patient years, which was not statistically significant. The rate of recurrent hospitalization for any cause between the two arms, and this was not significant. And the New York Heart Association functional class 1 or 2, that was in favor of the device arm. And you can see here a summary of the results of the trial. In the primary endpoints, rates of heart failure hospitalization or cardiovascular death, 36% reduction, risk reduction, rate of recurrent heart failure hospitalizations at 12 months, 41% relative risk reduction, and KCCQ overall summary score at 12 months, 11 points in quality of life. And in the secondary of life, you can see you were 2.35 more likely to be in your Heart Association class 1, 2, or 12 months if you were in the device arm. And you can see the difference in favor of the device in the 6-minute walking distance at 12 months. And let me finish with 2 slides from the meta-analysis that has been published in the Journal of the American College of Cardiology soon after the presentation for RESHAPE-2. As you can see here, for hospitalization for heart failure at 4 months, there was, as you can see, this was in favor of mitral clip of the device, and the same was also true for the composite of death or heart failure hospitalization through 24 months. And it was in the right direction, but cross the one, the death from any cause from baseline to 24 months. 0.76 was the overall, and it was from 0.57 to 1.01. This, dear colleagues, was in brief the presentation of the results of the RESHAPE 2, and I'm sure that we'll have time to discuss in more detail.
Thank you very much, Gerasimos. I think it is important to announce that we are listening to our audience. Everyone can engage a discussion using the chat line. If you want to ask questions, use slido.com that you see in your browser. As we listen to our colleagues who are online, I have the first question, Gerasimos, is that in summary, if I understand, the new knowledge after COAPT and mitral FR is that overall, even if we treat patients with less than severe MR, which was a very strong assumption for the COAPT phenotype, even if EMR is less than severe, we still can identify a benefit in these patients. And probably this is an important aspect because what we have seen in the last few years, the drugs we are using in heart failure, they're very effective in reducing the entity of MR. So can you elaborate a little bit on this?
I think that you are right, but I think, Francesco, that this is the first trial in slightly different populations, and I think that this trial confirms that we have benefit for the patient in the population of patients with heart failure and functional MR. When we see that we have suboptimal implementation of a new treatment, I think this is also the case with mitral clip. For me, let's say that the results are reassuring that not for patients with moderate to severe, that you are right, this is what we've seen compared to the previous trial. But if we have under treatment we don't implement treatment even in patients with more severe, I think that my conclusion is that treating functional MR with devices is beneficial for the patient, and we should use it more often in everyday clinical practice.
Now, there is a question from one of our colleagues. The first question is there any data on LV reverse remodeling in treating patients with moderate MR from RESHAPE 2? I also can answer that there is evidence in the expanded registries that those patients with moderate MR have a very important reverse remodeling, which is probably an important message here. That shows that treating patients earlier has a greater impact in reverse remodeling. On the other hand, also important to reinforce the concept, we are not talking about an alternative to guideline-directed medical therapy. We always have to remind that this therapy is a complementary solution which can be used to implement and to probably improve compliance in GDMT. But what about the RESHAPE 2? Did you observe any reverse remodeling in these patients?
I think that if we want to give an answer about yes, we have, and you can see in detail the data have been published in Global Cardiology a couple of months ago, and the data that I've shown in one of the slides was from this paper. But I think that, first of all, I'm sure that Julia will have more data to present on reverse remodeling from mitral clip. But I think what is extremely important is that we have clinical data from two trials and from the registry that you mentioned, that we have clinical benefit and we have events, decrease in events. So we have data in reverse modeling, but I think that I would use this data more, as you said, to try to explain why we see this benefit and try to identify the population and the patients who benefit more. And this is something that we've seen, as you know, in RESHAPE 2, than to understand better the pathophysiology of mitral clip that you have has been already presented over the years.
So I want to ask Dr. Rudolph, Professor Rudolph, who is also online, because we are all here trying to interpret this data. There is a question from one of our colleagues online who asks, the inclusion EROA criteria are similar between mitral FR and RESHAPE 2, and why do we see a difference here? It's a very difficult answer, to be honest. Why the data are so different? Is it because of, my interpretation is because we are now more experienced, because, there is more implementation of GDMT? What is your opinion?
Well, I think, first of all, thank you very much for having me here. And I think it's an excellent question. And I don't have a real answer, but I think one thing we really have to consider is that we still have, and I think everyone knows this from their practice, difficulties in just quantifying secondary mitral regurgitation. And in my experience, effective regurgitation or orifice area is something that we always use in the trials, but it's probably not the ideal measure to assess the severity of mitral regurgitation. And so I guess this explains a lot of the variation we see in the trials. And it's also interesting to look at other parameters that we use to quantify mitral regurgitation, where the differences are not so large between the trials. And so I would not be so sure that MRs were really so different between these trials. Indeed, I don't know what your take is on that.
I think my take is a bit philosophical, but I would say that we have been too much obsessed by measures, by numbers. We gave some numerology behind these patients. These patients are very complex. I think one of the biggest learning points is that the overall concept of proportionate versus disproportionate MR is now debatable. I think we need to realize that these therapies, again, should be used as a adjunct to guideline directed medical therapy, also to increase the dosage, to improve the compliance to therapy. And this has been shown in some registries. We need more data again, how to strategically combine structural interventions and medical therapy. I think this leads me somehow in a real world, because, trials are interesting. They give us a lot of information, but on the other hand, they're somehow far away from the individual cases. So I would like to play with one case example from Julia. You prepared for us one case to be discussed, and this will create even more discussion. So why don't we go forward?
Thank you so much, Francesco, and it's a great honor to be here with you. Actually, it's the previous slide. So we start this case. We have a 75-year-old male patient who is complaining of shortness of breath on exertion, and he doesn't have paroxysmal nocturnal dyspnea, and he's in New York Association class 3. As you can see, coming to the clinic, his vital signs, his blood pressure is relatively stable, 128/81 millimeters per mercury, heart rate 85 beats per minute, and he saturates 96% on room air. And he has this ECG that demonstrates atrial fibrillation with left bundle branch block, and actually he had an X-ray that demonstrated cardiomegaly and also mild pulmonary congestion. His BNP was raised on 1016, and he has mild renal impairment. and actually his white cell count and platelets were entirely normal. So from his medical background, he had a bypass operation in 2006 with Lima to LAD, a right actually internal mammary artery to RCA, and he has saphenous vein grafts to O1 and circumflex, and he had a non-stem in 2014. And he has been treated with edoxaban for atrial fibrillation, and he has hypertension, hypothyroidism, type 2 diabetes, and previous varicose vein ligation, and he has been an ex-smoker. It's important to mention that he had a recent angiogram in the context of his investigations, and he had the patent Lima 2 LAD, the patent right actually internal mammary artery graft, and he had an occluded saphenous vein graft to circumflex, which is backfilling from the LAD. He was on good medical therapy when he arrived in clinic. He was on furosemide of 40 milligrams once a day. You can see the nitrate, statin, metformin. But then we start him on spironolactone 25 milligrams twice a day and dapagliflozin 10 milligrams once a day. And he also takes already bisoprolol 5 milligrams once a day. Then this is his resting echocardiogram that you will appreciate from the parasternal long axis. We realize that his ejection fraction is slightly impaired in the context of significant mitral regurgitation, and we can see first that the mitral regurgitation is eccentric, posteriorly directed. And even from the color mode, we understand that this is to the upper limits of moderate mitral regurgitation. And then from the apical four-chamber view, we are trying to identify the jet. Because it's very eccentric, it's also quite difficult to understand the severity of the jet. But then we calculate ejection fraction 48% in the context of more than moderate, I would say, mitral regurgitation. We quantified mitral regurgitation as moderate to severe, and then you can see the effective regurgitant orifice area was coming up to 30 millimeters square, vena contracta 0.6, and then the end diastolic diameter 52 millimeters. The left atrium, as we saw, was dilated, and he had raised filling pressure with moderate tricuspid regurgitation. 55 millimeters mercury was measured the right ventricular systolic pressure. And then what we performed is to assess better the mitral regurgitation. We performed a TOE that you will see practically that I want all the videos to play, hopefully. So you will see that this there is actually significant, I would say, now we call it close to severe, eccentric, moving close to the P2 origin, to close to P2 mitral regurgitation, which is primarily ischemic, functional mitral regurgitation. And again, we were trying to identify the correct vena contracta and the orifice area, which is, as we said, a little bit difficult to do, especially in eccentric ischemic mitral regurgitation. And you can see here such an example that we tried to measure the vena contracta was coming at 0.45, and then another measurement eventually 0.6, and then you can see this dense jet of mitral regurgitation. So at this point, I think with your help, Francesco, we have this poll for our audience. How would you treat the patient up to now? Would you offer open heart surgery? Would you offer a mitral edge-to-edge repair? Or would you keep on medical therapy or, of course, up-titrate medical therapy?
Thank you, Julia. This has been it's a very nice case, actually, to discuss. There are many ideas I have in mind, and I will start asking both Gerasimos and Volker. First of all, when we have a patient like this, the questions are the following. Number one question, should we improve the quality of life of this patient? Number one. Number two, should we avoid this patient to have acute hospitalizations? And can we improve prognosis in terms of survival? And I will start with quality of life. Now, this patient is in full therapy, has many medications. Many of these patients survive, but they have a bad quality of life because they have to go and pee multiple times in a day. They have to survive with a very low pressure and so on. how quality of life plays a role in the decision making for MTR. Volker, you are doing many of these cases. What is quality of life today? And then I will ask Gerasimos, what is the perspective from heart failure? How quality of life plays a role in taking a decision? So, Volker.
I mean, I completely agree. This is a very important point, and I mean, in my experience, most patients that come to us, this is the most important topic for them. They don't ask for prolongation of life or whatever. They ask. They have their problems. They have shortness of breath, which is sometimes really disables them to perform daily activities. And if you can improve that, that's the most important topic for them. And we learned these things now over many years in the mitral and also tricuspid side. This is really what matters to people. So we should not downplay these issues.
Yes, and so Gerasimos, obviously you are the heart failure. By the way, you can see here represented more or less everyone. So we have an imager, heart failure, interventionist, and surgeon. So the stakeholders will see how surgery plays a role here in a few moments. But what about you? What do you think?
Let's see the different angles. You're right. First of all, I think to start with, we all agree that what you said before is what we want for all our patients. Improve quality of life, reduce hospitalization, that also improves quality of life and improve prognosis. And of course, if it's possible, to improve survival. And it's true that it has been shown several times in the past, not only for our personal experience, that many of the patients usually with more advanced disease, that they are ready to, many of them that they are in the transplant list or in advanced heart failure, that they are willing to exchange a significant amount of the remaining life with better quality of life. But having said that, we need to understand that if we want to be philosophical, like our chair usually is not always easy to measure quality of life. Even today that we have so many scales, so many questionnaires, so this is the first that we know, and I say that because of course we need to measure it, first of all, that we don't measure in everyday clinical practice, and if we measure it more, we find better questionnaires and better ways to show that we really improve it. If we go from this to the patient that we have, patient, you offered us 3 options. I don't want to say something about this because I think that probably voting is ongoing. Francesco, is it?
So the voting is ongoing at the moment. MTR leads the way for let's say for 75%, and there is an equal, head-to-head medical therapy and open heart surgery. We will discuss this later. So but I think most people here obviously are a bit biased, as you can imagine. They are pushing for MTR. What do you think?
Yeah. So I think that there are always ways to improve medical therapy. This patient had an ejection fraction above 45%, but this was with the EMR that we've seen. So you can always find an excuse to give more, let's say, renin-angiotensin inhibitors, ACE inhibitors, or ARB. I'm not sure if this was the case for this patient, because also you have started Spiro in this patient. This patient is on 40 milligrams of furosemide. If this patient is highly symptomatic, many people will argue, okay, before going to to mitral clip or surgery, and some suggested you need probably to do something to improve congestion, and probably you need more than 40 milligrams of furosemide. So one of the good and the bad things, dear colleagues in medical therapy, Francesco, is that you cannot always find something more to add or say, and there is always an argument against this. So these are my thoughts about medical therapy. I don't want to say anything about surgical therapy in front of you, but I will say something later. I'll tell you my opinion later on this.
So then why don't we go back to the case and see what has been done and what has been the experience of the patient.
So, excellent. So then back to the slides. We will see how we discussed this patient in heart MDT, and we felt actually that the patient had, because of the previous bypass operation, had a decent Euro score for redo surgery in order to repair the mitral. And of course, mitral was the predominant lesion because TR was moderate and there was no significant coronary artery disease. And therefore, we felt that the anatomy was suitable for mitral edge-to-edge repair. And then we decided that we would go first with towards the structural intervention with a backup of surgery. And then, as you can see, this was quite straightforward. I would say that we tried to position the clip posteromedially, and then practically with one clip led to successful resolution of mitral regurgitation, ending up to significant improvement of the LVOT VTI, and of course the residual mitral regurgitation was mild. You will see here that the mean gradient post the procedure was 3 millimeters per mercury. And I will show you the transthoracic echo post-procedure that, of course, now that we have eliminated the mitral regurgitation, to our eyes, the ejection fraction dropped slightly, a little bit below 40%, and then the mitral regurgitation was mild. There was significant improvement in exercise capacity. The patient 3 months later has been free of symptoms. He describes that he feels much better. And practically, I want to mention that when the patient was being discharged, what we felt that was appropriate as a first step is we up-titrate spironolactone, then we added sacubitril valsartan, and usually what we do is the general practitioner will then titrate further any other medicines such as furosemide that needs to be titrated. So this was the outcome of the case.
Thank you, Julia. I want to start with the last words that you mentioned. You introduced the hernia at the end, and this is probably the first point. We are giving this therapy as an option not to decrease the medical therapy, but to increase it, because most of these patients, they will be supported by the 4 pillars of medical therapy, even better than before. But on the other hand, also they can do it because they have probably higher blood pressure, more efficient LV function, and that is a very important point. The other point I would like to mention, and it's a spoiler to the next presentation that Professor Rudolph will give us. This was a patient with the tethering of leaflets, is a ischemic MR, which is somehow considered not the ideal candidate for clipping usually. Is a bit higher risk for failure, although in this case was a perfect outcome also because it was a central regurgitation. But also important to say it is a typical patient with disproportionate MR to some extent, because it's a somehow normal or let's say not too bad LV function because of the ischemic origin of this mitral regurgitation. So in principle, that was, I think, a good idea to treat this patient with MTR, and I'd like to know the opinion of Volker Rudolph.
No, I'm very much agree to what you said, and I think it's especially the first part of what you mentioned. I mean, we saw in COAP, then they put a lot of effort to really up-titrate patients with medications, and what we saw is that only 38% of patients were able to receive a triple heart failure therapy, which was the appropriate thing to do at this time. And so this tells us, and I mean, a lot of this was, as we all know, hypotension, renal function that spoke against further up-titrating medication. So I mean, really, most of those patients were only able to receive 2 drugs, and that shows us that here we have a great opportunity actually to create a synergism between these therapies and not to regard them as opponents over which we have to fight. I think it's really there are so many patients with advanced heart failure and secondary MR which struggle with their medication, and I think in the end, like this, we can also come back to quality of life, because if you then have to up-titrate now sacubitril valsartan, they will have a bad time because of hypotension. And so if you can do this after treating MR, you might improve their quality of life. And by giving them sacubitril valsartan in an appropriate dose, you might as well improve their prognosis. So you have all of it. And so I think we have to work together on this.
Yeah, and we have seen in some retrospective registries, Marianna Damo published 1.5 years ago data that shows that those patients in which the therapy has been up-titrated by increasing doses or adding new drugs, actually they have a better prognosis. So and I think this is the most important message here, that we are learning somehow how to combine therapies. Although, Gerasimos, we don't have yet trial data on strategic trials. It would be nice to have a strategic trial to test the hypothesis of improving the drug therapy after structural interventions.
You are right, but I think it would be difficult to have this data in a trial outside registry. So I think from registries or from the trials or from the mitral clip trials is the only opportunity, because it would be difficult, as you know, to design a trial and say I will use mitral clip to see if I could titrate therapy better, because as we discussed today, this is part of the therapeutic protocol, mitral clip for this specific patient. So I think the best way to have this information is what you and Rudolf suggested, from the follow-up of patients in the different centers, and have a registry where in more strict way you can see this data. And we have some very good registries. This is something probably could be studied in the Swedish registry or in the other large mitral clip registries, I think. Sorry about the coughing.
No worries. There is a question now, which is I am happy to take this question. Should we change the cutoff of severity of ARO-IA calculated by PISA in secondary MR? To be honest, it's back to the future. You know, in the guidelines, the European guidelines, we have been always saying that the severity severe was defined by EROA more than 0.2, and then there has been a change because we wanted to be in line with the American guidelines. But this goes into the discussion on how do we define severity? Is it because is it a grading, or it is a clinical impact of a grade?
If you allow me, just on the same line, Francesco, because I know your view. You said that for several years, and I think this is also the view of Professor Grafsa but also others. When I see, or when I ask from my imaging experts to evaluate mitral regurgitation never, the severity is never an easy process. So you cannot say, in my opinion, and Julia, you are the expert, correct me if I'm wrong, is not that you have a magic number, that you say, I have this number. Of course, we all need, especially the non-expert, a number to make our life easier. But it's what you said before. You need more than one number to evaluate the patient with heart failure and mitral regurgitation. And I think this is one of the reasons that we have all this discussion, because if we want to make our life easier, and this is not only in mitral regurgitation, but in several other areas, we want a number. And just to make it easy, if it's above this, it's severe. If it's below, it's not. And we use the same for heart failure. We want to use it. If it's above, this is heart failure. If it's below, it's not, which is not easy. I think you are right, and this is something that is the message to me from all these years in heart failure, especially from these patients. You need something more than a number.
And you know, just to add a very quick comment, that's a multi-parametric approach. We have several indices. We see the left ventricle, the function. We have availability TOE. We have also exercise echo, the stress echo. The value of this is incremental in the decision of the severity of MR. And then, of course, we judge in a heart MDT with symptoms, medical therapy, and all available imaging tests. So it's a multi-parametric approach. It's not one parameter only.
And now you mentioned the MDT, and also I want to go back to the poll where 10% of our audience have been voted for surgery. And this links us to the next lecture from Professor Rudolph, who has been a co-PI of the MATTERHORN, a very difficult trial to enroll, but finally you were able to publish and share with us what you learned.
Yes, thank you so much for sharing the results here again. I will directly jump into it. MATTERHORN was a multi-center controlled non-inferiority trial, which altogether randomized 210 patients in a one-to-one fashion, and we randomized patients to edge-to-edge repair for the mitral valve, or surgical mitral valve repair or replacement, and this was left at the discretion of the surgeon. And there were also additional procedures that the surgeon was able to do at his discretion. And to be eligible for the trials, patients had to have secondary mitral regurgitation defined by the criteria here. And those criteria, as you can see, were also oriented a lot on the old European guidelines, because this is when we started the trial. Left ventricular ejection fraction had to be 20 or more, and there was no upper limit. Actually, the upper limit was removed throughout the course of the trial. Patients had to have high surgical risk determined by a heart team consensus. They had to be symptomatic despite guideline-directed medical therapy. No other severe valve disorders were to be present, and no revascularization or CRT device was to be implanted within 30 days prior to enrollment. The main endpoint, the 1 year primary efficacy endpoint, was a combination of death, heart failure, rehospitalization, mitral reintervention, assist device implantation, and stroke. The trial was also powered for the key secondary endpoint, which was the recurrence of mitral regurgitation grade 3 or 4 at 1 year. And the primary safety endpoint was assessed at 30 days, was a combination of 14 different major adverse events. This is the baseline characteristics of the cohort, and I highlighted the most important ones in orange. So the mean age of the population was 70.5 years. A little less than half had coronary artery disease. Half of the patients had atrial fibrillation. According to the scores, Euroscore 2, surgical risk was not all that high. But patients were very symptomatic. So we had 85% of patients who had at least New York Heart Association class 3 dyspnea, and 83% of the patients had a heart failure hospitalization within the last year. And importantly, and this is very similar to RESHAPE, effective regurgitation orifice area was 0.22. And this is now different to all the other trials we have so far for mitral HFrEF repair and secondary MR. The left ventricular ejection fraction was 43%, so much better and reflecting a population, obviously, that was accessible to surgery as well. So the primary endpoint of the trial was observed in 22.5% of patients in the surgical cohort and in 16.7% in the TEER cohort. And this was not enough to show superiority of TEER, although it was numerically better, but it was, of course, enough to prove non-inferiority of TEER versus surgery. We also already did some sub-analysis and looked at the main mechanism of secondary MR. And so if we looked at patients who had more an atrial type of functional mitral regurgitation, we saw that the curves were very similar between the two treatments, whereas if tethering was the main mechanism, so if it was more ventricular mitral regurgitation, then we saw again that and even a little more than in the main results, that MitraClip was a little better numerically than surgery indeed, but statistically these analyses only again showed non-inferiority, which without any statistical superiority of TEER against surgery. But I think it's still interesting to look at the data this way. Now, with regard to the key secondary endpoint of MR recurrence at 1 year, we saw this in 8.9% of patients in the interventional group and only 1.5% in the surgical group. So there's a numerical difference. Again, formally, this is enough or was enough to show non-inferiority also with regard to this endpoint for TEER. If you look at the echocardiographic analysis, reduction of MR to MR2 or less was almost similar between the two groups. But again, reduction to MR1 or less, it was numerically better in the patients who underwent surgery. So if we now move to the primary safety endpoint at 30 days, this was observed in 54.8% of patients in the surgical group and in only 14.9% of patients in the interventional group. And this was now also statistically superior, and this difference remained statistically superior at 1 year, showing much fewer safety events in the interventional group. So taken together, the trial shows that TEER is non-inferior to surgery in secondary mitral regurgitation at 1 year. Numerically, we really see a trend towards a higher efficacy of TEER in patients with a tethered leaflet, so ventricular mitral regurgitation. We see a clear signal for a superior safety profile of TEER against surgery. But also we only have a follow-up only of 1 year, and we are performing a longer follow-up now, and this will be very, very important, of course, to see how in the long term maybe differences in efficiency of reducing MR will affect outcomes of patients. Thank you.
So thank you, Volker. So it appears, therefore, that at least a 1 year follow-up, there is non-inferiority of TEER in terms of the strong endpoints. There is superiority in terms of safety, and somehow there is a trend to have better MR reduction with surgery. But obviously, you probably didn't mention that there was 1/3 of patients in the surgical arm being treated by replacement, correct?
Mm-hmm. Correct.
So this obviously has an impact on MR reduction, where obviously the MTR group is only repair. But it's interesting also to link to the Julia Grapsa case that you have shown that particularly in the patients with tethering, TEER has been superior to surgery. which is somehow well known because we know that annuloplasty fails in patients with tethering, and so we are not seeing something unexpected. What do you think about it?
Yeah, no, I think it's very interesting to see now in this trial and what we are currently doing and what we know that people have done, but we have not formally analyzed it, is that subvalvular techniques such as papillary muscle approximation were used in the trial. And I think this apparently makes a huge difference if we compare this to prior data, for example, from the CTSN trial, where we saw in patients with secondary MR and surgical reconstruction that recurrence rates at 1 year went up to 30%, 2 years 60%. Now we have 1.5%. So I think the surgical community learned to address these issues. But still, I mean, it looks there's still a little bit of an effect, and tethering is just harder to tackle for surgery.
But now, so let me ask you the very hard question. What? So please, here.
So yeah,
Yes.
so I think it's something that I know your opinion, but I think this would be very useful for this for this webinar. First of all, I think that Volker has already said that, and you can see that just from the ejection fraction, this patient in the trial should be candidates both for surgical and transcutaneous operation. So these are different, in my opinion, from the patients in the mitral clip trials. They are in more severe condition. The second is, after the results of the trial that was very well conducted with very good criteria, what is the role of the cardiac surgeon in, or if you prefer to make it better, or who has the ideal patient for surgery in functional MR?
Yeah, that was the question I wanted. Is the same question I wanted to ask to Volker, because obviously after this trial, the idea is that surgery is dead. So I ask Volker, in your practice, who are the patients where you still consider surgery after you have been involved in this trial?
Yeah, no, I mean, what we really want to point out, I mean, results for surgery were really good. So we had very efficient reduction of mitral regurgitation, but this came at the price of a very, it was 50% of patients who had really severe adverse events. So, and not every patient can pay this price, as we all know. So I really think you have to have an argument why you want to do surgery in these patients. And I mean, we all know there are arguments. There could be concomitant procedures. I think in my practice, it's mostly severe advanced coronary artery disease, where you want to do CABG along with mitral reconstruction, which could be arguments to still do surgery. If it's isolated, it's really a tough question where you really want to do it, because I mean, it's the safety price you have to pay. One thing that probably, although we have to consider, is, I mean, we have to wait for these longer term results. If patients are very young and have a well preserved left ventricular ejection fraction, and you really look at long term outcomes, 10, 20 years. I would still be a little reluctant to say, okay, in a 40-year-old, let's go for mitral clip. I mean, this would have to be thoroughly discussed depending on the individual situation. And for this discussion, I think we have to wait for longer term results. But I mean, most patients that we see are in the age of the patients that we had in the trial, 70 years or above. And I think for those patients, we somehow have an answer here.
But anyhow, just to conclude the discussion on surgery, there are two elements that have to be understood by the audience. Number one, it was difficult to enroll in this trial. How many years? I think 10 years to enroll patients, and to enroll 200 patients, 104 patients in each group. And the second one, at the end, obviously the population which has been enrolled is different from the population of RESHAPE or the population of COAPT. There are at least 10 points difference in the average in the ejection fraction, in the left ventricular ejection fraction, which underlines that the patient to be considered for surgery are not the end-stage heart failure patients. We have to realize that, as you mentioned, these patients are very high risk for surgery. The role of surgery probably, in my opinion, remains in those patients who are younger with atrial FMR, where we can get good results, particularly if you combine the mitral valve repair with the restoration of sinus rhythm and surgical ablation of AFib. This could be a very important subset of patients where we should discuss. On the other hand, in my practice, after many trials were being non-convincing, if a patient has a ischemic MR and requires revascularization, unless the MR is truly severe, I tend to not to treat MR at the time of surgery. We do beating heart revascularization, and we see what happens. And in case MR remains a problem, we still have a second option of edge-to-edge, because honestly, many of these patients may recover. I have to also, there's been a lot of discussion, a lot of questions, and some answers as well. I like the fact that the audience have been somehow answering each other regarding how to quantify MR. Again, although Gerasimos has been very clear in stating that we should not have a simple single measure, there has been discussion about what is the better methodology. And so one quick question to Julia: do you think stress echo plays a role in patients where we have a doubt?
Yes, so thank you so much, Francesco. I think that's very important to have a low threshold to use exercise echo, because in those patients with eccentric MR, those patients that they have disproportional symptoms and we still feel that the MR could be moderate, then we do exercise echo, and then we see that the MR really becomes more severe. Or, of course, we pay attention to the pulmonary pressures, that they will increase, and then there is an indication to treat this MR. So never underestimate the value of putting a patient on the bicycle, if they can, of course, and exercise them and see the effect of exercise.
Thank you. And we are going towards the end of our time, so I need to somehow conclude. I want also to thank the audience for lots of questions. Some of them we are being not able to answer because we have a limited time. One above all, there is one question regarding the patients with non-ischemic MR, whether in RESHAPE 2 you have been looking at the gene expression and the biopsies. Obviously, you know, there are many aspects for these therapies. You know, these patients are very complex, and we do a lot of tests. Maybe in future even gene expression. But let me conclude with the take-home message. Let's say a summary slide that I prepared. Let's see the next slide, please. To somehow bring home a few points. RESHAPE 2 suggests that in heart failure patients, even with moderate MR, so in patients who are below the COAPT criteria, MTR, in addition to guideline-directed medical therapy, may improve quality of life, reduces hospitalizations, and we have seen that in meta-analysis there might be a mortality benefit. MATTERHORN has shown that TEER is non-inferior to surgery, mainly because of a better safety profile. So these findings are somehow informing us on better timing and treatment choices for symptomatic heart failure patients. longer follow-up and further data are always needed to optimize outcomes in this high-risk population. We need to look for synergistic therapy strategies. We need to understand that these therapies are not an alternative to medical therapy, but they can be together more effective in treating these patients who really require a lot of efforts to improve quality of life and survival. With this, I'd like to thank Gerasimos, Volker, and above all, Julia, who brought us a great case to discuss. Thank you for not only Gerasimos and Volker, but also to all the investigators who have been working hard to collect the data and help us understanding more features of this pathology. And I really thank the audience for being with us. And I look forward to see you in next webinars, and follow us on PCR events, London Valves, as well as a new focus group, which is going to be opened recently on secondary MR, because actually with the new evidence, there is need for more discussion among the experts. Thank you very much, and see you soon in next events.